All right, everybody, here we go with part 3 of an introduction to stuttering. So we've already talked about what stuttering is. So now let's talk about the cause, onset, recovery, things like that. First, let's do some terms quickly. In the U.S., the term for speech-language pathologists is stuttering. But in British English, it's going to be stammering. So here in the United States, we have the National Stuttering Association, which is a big support group for people who stutter. In Britain, it's the British Stammering Association. In India, it's the Indian Stammering Association. So it means the same thing. Just in the United States, we use the term stuttering. Abroad, they'll often use the technical term is stammering. We're really going to only use the terms disfluency and stuttering. DIS, disfluency, is the fluency breaks of neurotypical speakers, so all those ums and uhs and likes and things like that. DYS, disfluency, was a term to discuss the abnormal fluency breaks of people who stutter, or maybe people with aphasia or something like that. And it's really not a term used anymore. So we're going to use the term disfluency to describe those typical disfluencies that everybody has. And then if we're talking about stuttering, we need to use the term stuttering. Also, just quickly, I know that ASHA still wants us to use person first language. When we submit anything to ASHA or ASHA journals, we have to use person who stutters. However, we're starting to move away from that. At least people who stutter are, and people with autism and others as well are moving to the term either calling themselves autistic or calling themselves a stutterer rather than a person who stutters. There are lots of reasons for that, but the reason I like to use, and I tend to use them pretty interchangeably, but my wife runs a lot. She likes to run long distance, and if you called her a runner, she wouldn't be all upset and say, no, I'm a person who runs, I'm much more than just a runner. No, she'd be fine with that. And the reason for that is that running's not a bad thing. So what if stuttering wasn't a bad thing? What if having autism was not a bad thing? Then it would be okay to be a stutterer or an autistic or whomever. So I use these terms interchangeably, and then here in the slides, sometimes we'll use abbreviations. We'll use PWS for person who stutters, CWS for child who stutters. But I've also heard people say, I don't care if you call me a stutterer or a person who stutters, just don't abbreviate me. So, no matter what you do, no matter what term we use, there's going to be someone out there who prefers one term over the other. So I kind of just use all three throughout this presentation. So etiology, about 70% of children who stutter have a stuttering relative. About 25% have a parent, usually a father, because more men stutter than women who stutters. And we don't have a lot of good research on identical twins who stutter, but somewhere between 60% and 2% and 2/3 of identical twins where one twin stutters, the other twin also stutters. But only in the old, now pretty old Howie study from 40 years ago, only 19% of fraternal twins stuttered. So, right, that tells us that stuttering definitely has a genetic basis, but it's not 100% genetic, right? There are other factors involved. So we believe that there's a genetic link in 50 to 70% of people who stutter, probably more toward that 70% mark. Dennis Drana is a big researcher at the NIH. He's one of the few people in the world who his only job is to study the genetics of speech and language disorders. And he and his colleagues have identified 4 genes that probably account for about 20% of all people who stutter are on those 4 genes. But they've got a ways to go here. And speaking is such a complicated process that it's going to end up being multiple genes involved in stuttering across multiple chromosomes. So we're just in the early beginning stages of all this stuff. And then what about those people who do not have that genetic family history? And what's hard is, it's not unusual to do a assessment with a family, and you ask them, is there anybody in your family who stutters? And they say, no, it's just our 4-year-old. And then you have therapy with them, and 2 months later, mom is like, I was talking about, my child being in speech therapy with my mom, and then she remembered that, her uncle used to stutter. So, a lot of times there is a family history, and people just don't realize it because they don't talk about it. It's not like everybody goes around at Thanksgiving talking about, who in the family had a speech and language disorder. It's just not that. It's just not a topic of conversation. So often people don't know it until, maybe after they've already done the assessment with us. So, however, there are definitely people who stutter without a family history. And those people are going to have greater incidence of complications at birth. So loss of oxygen, instruments being used, and then also early head trauma, more likely to have early diseases, possibly especially strep type diseases, and then early surgeries. People who stutter without a family history also have greater incidence of attention deficit disorder symptoms or diagnosis, and increases in anxiety. So we've got extra links here. People who stutter are much more likely to have attention deficit disorder than people who do not, are much more likely to have dyslexia and Tourette's than people who don't. So we have a lot of similarities with other neurological disorders going on. All right, so when does it start? Developmental stuttering is a disorder of early childhood. So the vast majority of stuttering onset occurs from age 2 to 4. Anyone who ever starts to stutter, 85% of all those who stutter begin by age 3.5, and I believe 95% of anyone who starts to stutter will start to stutter before age 5. So the vast majority of stuttering is going to occur early on. And then about 75% of children who stutter will recover, where the stuttering will just no longer be a factor in their speech anymore. So at onset, the chance of recovery, like we said, is 75%. 1 year after onset, if the child is still stuttering, their chance of recovery drops down to 63%. But after 2 years, they're down to 47%. After a child's been stuttering for 4 years, that chance of recovery of them becoming just a typically fluent speaker is going to drop all the way down to 5%. So, the vast majority of kids who stutter are going to start by age 3.5 or 4, and they're going to stop stuttering by age 6 or 7. So, the vast majority of stuttering is in younger kids. People like me who stutter into adulthood are only about a quarter of everybody who ever stutters. All right, predictive factors. So who is most likely to continue to stutter or to stop stuttering? So family history is the strongest predictor. If relatives have recovered from stuttering. So if a child has a parent, aunts, uncles, grandparents who stuttered but recovered from stuttering, they don't have a 75 chance of recovery, they have a 65 chance chance of recovery. However, if they have a family member who continued to stutter into adulthood, they have a 65% chance of following that, which means they have a 35% chance of recovery. So if you have a family member who stutters right off the bat, you do not have a 75% chance of recovery. You're down to a 35% chance of recovery. Gender is also a big factor. It's going to be the girls will recover more often and faster than boys. Usually girls will start to stutter a little bit earlier than boys. That gives them a little bit more time to recover. Girls also have just a little bit stronger speech and language skills than boys do, which may also help them to be more likely to recover. Age at onset is also important. The earlier you are when you start to stutter, the greater the chance of recovery, right? If you start to stutter when you're 2.5, your speech skills, your language skills, your voice is going to change a lot from 2.5 to 4.5, and your stuttering is going to change too. So there's a good chance, if you start at 2.5, it's not surprising that when that child is 4, they are a typically fluent speaker. However, if we have a child that starts to stutter after their 4th birthday, that child's going to have a much greater chance to persist with their stuttering because they're already talking at, a fairly, not quite adult-like, but we're getting there. So their speech, their language, their voice aren't going to change nearly as much, and so their stuttering isn't going to change that much either. Just a little bit about prevalence. So overall, about 1% of the population stutters. About 2.5%, maybe a little bit higher, of kindergartners stutter. And then again, these kids are going to be more likely to recover. So about 1% of school-age kids stutter. And then by the time we reach adulthood, maybe half of 1% of adults stutter, maybe a quarter of 1%. We're not really sure, but again, it's going to drop as people get older because people are going to recover. Even if people only have a 5% chance of recovery after they're 8 or 9 years old, that's still, 1 in 20 kids who stutter are going to stop stuttering. Incidence, so prevalence is how many people stutter right now. Incidence is how many people have ever stuttered. So if you ask adults, do you stutter now or have you ever stuttered, about 5% of people will say yes, at some point in my life I stuttered, either as a young child or maybe I had a head injury, maybe I had a concussion in a baseball game or football game, and maybe for like 3 months I stuttered, or a car accident, but then it just went away, or as an older adult because of a stroke or something like that. So about 5% of people at some point in their life will stutter. Gender differences. So it's going to be the girls are going to start to stutter a little bit earlier. They've got stronger language skills. They're talking more earlier on. So they're going to start to stutter earlier on. And again, that's going to help them to change the way they talk because they have more time, more plasticity in how they're speaking. They're going to stop. They're going to recover. It's going to be the boys who are less likely to recover. So by the time they're adults, we're at a 4-to-1, 5-to-1 sex ratio here. And that's a pretty similar ratio. That 3-to-1 to 5-to-1 is going to be found in other speech language learning disorders. Right. All right, just a little bit on fluency-inducing conditions. So what things are going to help people talk more fluently? And this comes from really old research by Oliver Bloodstein. Speaking slowly, speaking when alone, speaking to an animal or infant, speaking in unison with another speaker, listening to delayed auditory feedback, and singing, right? So speaking slowly, speaking when alone, speaking to an animal or infant, right? So the slower you do any motor task, the more just the easier it is to do, right? Whether you're driving or you're writing or typing, right? The faster you go, the less accurately you're going to do it. The slower you go, the more accurately you're going to do it. When you're speaking by yourself, you're talking more slowly. You're also talking about things, obviously, that you know about. You're choosing the topic, no one else is. There's no back and forth speaking. Speaking to an animal or infant, right? We add in that motherese, that parentese, where people talk, a little bit more of a sing-songy voice. It's slower. It's simple, short sentences, right? Talking about things right in front of us. So anything that makes talking easier is going to lead to more fluency. Speaking in unison with another speaker. So a lot of kids who stutter will realize that when they go to church on the weekend and they're speaking or reading something in unison with everybody else, all of a sudden they are really fluent. And so what's going on is having that model from other people. So they're getting feedback about how to speak in real time as they're speaking, and that increases their fluency. So at first people thought that this was because, you're not carrying the message, so it doesn't even matter if you're talking because other people are talking. But then if you put somebody in a room who has a headphone on and that person, is reading to 100 people, they're going to be fluent if they're listening in their headphones to somebody, to even a recorded version of themselves talking in their head. So, on their headphones. So it's really about that. Feedback is really important. So there are delayed auditory feedback devices, such as the Speakeasy, that are going to work to help people stutter less. Unfortunately, these are really only short-term helpers, and wearing these long-term is not helpful. It's only helpful short-term. Last one is singing. Singing incorporates a lot of the things we've talked about. Slower rate of speech. You've actually memorized what you're saying. There's a lot of this. Plus, singing comes from the right hemisphere, right? So that it's really driven by that prosody, that rhythm. So it actually takes a different neural pathway when you're singing. And so it may completely bypass that area of your brain that's causing the stuttering. So that's why people, on average, are going to be more fluent when they sing. All right, stuttering variability, last thing to think about. This is a great meme. Unfortunately, he's not doing commercials anymore. It'll make me sad when people don't know who the Dos Equis man is. So I don't always stutter, just kidding, I do. So, right, I'm an adult who stutters. I stutter. I have days where I stutter a lot. I have days where I stutter very little. If I'm alone recording something like now, right, I'm going to be pretty fluent, right? But if I'm in a back and forth conversation with somebody where I talk, you talk, I talk, you talk, I talk, you talk, I talk, you talk, I'm not the one driving the topic. Maybe it's got to be a little bit faster. I might have a lot more stuttering. So one of the key, truths about stuttering is it's highly variable. Even the same person can have a lot of stuttering one day, little stuttering the next day, a lot of stuttering in the morning, little stuttering in the afternoon. So, like, one of the key parts of stuttering is that it is really variable. All right, let's do a little bit on assessment and therapy. We want to assess those core behaviors, the stuttering-like disfluencies. right? Remember, those are the short segment repetitions, the prolongations, and the blocks. Secondary behaviors, right? The escape behaviors and the avoidance behaviors. And then feelings and attitudes. So is there shame? Is there guilt, embarrassment, anxiety, fear, right? Some of the most common attitudes, and how are those impacting the person's activity and participation and their stuttering. We want to look at the parent's concern if the if the client is a child. And again, stuttering is highly variable. Parents are almost always right. So if we have a 3-year-old come in for a 45-minute assessment, that child might be fluent the whole time. But if I ask a parent and they can show me, let's say, what is he doing at home? What are you seeing? And they're seeing blocks, they're seeing prolongations, and they're able to show me that, I guarantee this is a child who stutters, even though I don't happen to see it during this half hour. Now, it's so much easier now with, so many people have smartphones. They can take a recording at home, be able to bring it in and show me what they're seeing. So that, that isn't as big a deal as it used to be. All right, so preschool therapy, there are 2 models. I really advocate for using an indirect model first. Usually the demands and capacities model, but there's also parent-child interaction therapy. The demands and capacities therapy is Starkweather, Gottwald, and Halfond. And they, that therapy is really about lessening the demands on the child's speech. So, and it's really an environmental therapy where the parents are going to slow down the parent speech. The parents are going to use shorter sentences. The parents are going to try to slow things down in the environment. The environment did not cause the stuttering. There's really no difference in the parents of kids who stutter versus kids who don't. But, because we have a child who stutters, we want to really drop those demands down way below what's average to try to increase that child's fluency. Parent-child interaction therapy is really championed by people at the Michael Palin's Center for Stammering in London, and that is based on demands and capacities. Where again, it's really parents changing the environment and working for the child. If the child is still stuttering, we're going to move to a more direct approach, and that can either be the lid comb therapy out of Australia with Onslow, Packman, and Harrison, and then we've also got gradual increase in length and complexity, where we're going to move up in a hierarchy from teaching the child to be able to speak fluently at the 1-word level, the 2-word level, and on up. And that's really the Inghams and then some other people out in California were big in the gradual increase in length and complexity, and that can be a nice way to do childhood therapy. So these are traditional therapy goals. So, right, once that child has been stuttering, remember, for 3 or 4 years, they're probably always going to stutter. So we've got things like, okay, can the child have some spontaneous fluency, some controlled fluency, some acceptable stuttering, right? But we've really, those are traditional goals, but we've also really broadened this out to, we usually a much more holistic therapy approach where we can talk about management of stuttering. We can talk about children being able to advocate for themselves. So lots of other good things, as well as just the stuttering. For years, there were 2 main kinds of sort of stuttering therapy camps. You were either in the stuttering modification camp or in the fluency shaping camp. Stuttering modification camp, really from Charles Van Riper. And Van Riper talked about modifying the moments of stuttering, reducing the fear of stuttering, eliminate the avoidance behaviors, and doing some easy stuttering and being okay doing some easy stuttering. So, and he had three main speech techniques. There are other parts of the therapy, but the speech techniques were the cancellation, the pull-out, and the preparatory set. The cancellation was you already stuttered, had a hard stutter. You've got to go back, kind of cancel it out, and practice stuttering in some easy stuttering, which is how Van Riper wanted you to stutter. So if I'm stuttering, I'm going to stutter, I'm going to pause, and then I'm going to say that word again in an easier stutter. So it's going to sound something like that, where I stutter, I pause, and then I stutter the way that Charles Van Riper wanted me to stutter the first time. The pull-out is I'm going to catch the stutter. A lot of therapists will call this a catch and stretch. I'm going to stutter. I'm going to catch it in the middle and stretch it out. So I'm going to have a stutter, and I'm going to turn that hard stutter into an easy stutter mid-stutter. So, okay, I didn't start out the stutter the way Charles Van Riper wanted me to, but I'm going to end it the way he wants it to. So I'm going to catch it, stretch it out mid-stutter, and I get to keep going. I don't have to pause. I don't have to cancel. I can keep going. Once the person gets good at that, they can practice doing a preparatory set where you're starting out with, like, this is like the last step in the cancellation, where I'm doing some nice, easy, forward-moving stuttering. And if I do that, I get to keep going. If I forget to do this, or if I get stuck and I have a real stutter, I then can pull out of that. If I have a harder stutter, can't pull out, forget to pull out, I then can go back and cancel it. So you kind of have things in your back pocket. You want to try to do the prep set. If you can't, you pull out. If you can't do that, you do a cancellation. Okay. And then, the other big thing about the stuttering modification therapy, and I mean, obviously there's a lot more to it than that, is, you're also reducing the fear of stuttering, eliminating avoidance behaviors. So working on feelings and attitudes, working on approaching situations and not avoiding. Fluency shaping therapy was the other camp. And in this camp, it was really just about working on fluent speech. And you were replacing the stuttering with fluency, just working on speech techniques. So one technique was a really slow rate of speech. You can combine this with relaxed breathing, using really easy breathing. Gentle onset is sometimes called easy onset, and it's a little bit short for gentle onset of voicing or easy onset of voicing, where we're going to start out really quietly when we begin our utterance, and then get up to a normal loudness level, normal tension level. So a very easy onset of voicing as we go. Continuous voice and movement is where I'm going to continue my voice and talk like that, with the understanding that as I go, I can start to get better at doing this, and I can have continuous voicing without it being quite so robotic. And the reason why this is helpful is because, in normal speech, it's voice sound, unvoiced sound, voice sound, unvoiced sound, voice sound, unvoiced sound, voice sound, unvoiced sound. It's harder. If you're continuously voicing everything, it takes out a big step of speaking, and again, it makes it easier. Then we've got light contact of articulators. So working on, on sounds like T's, D's, things like that, really touching very softly with your tongue. Also sounds that you'd make with your lips, an M, a B, something like that, making very light contacts and being able to still, move forward and not get stuck on those sounds. Last one is going to be normal phrasing and pausing. So we're going to really shorten how long we're going to say at once, knowing that shorter phrases are going to be more fluent than longer phrases. And again, practicing this, some people are able to get up to it sounding pretty normal when they pause and phrase. So these are just different, depending on the type of fluency shaping therapy you'd go to. Some would work on just one of these. Maybe they package a few of these together to work on, certain targets to help people be more fluent. I kind of like to use an acceptance-based stuttering therapy that takes acceptance and really combines the stuttering modification and the fluency shaping together, based on a little bit of mindfulness, so focusing on internal and external sensations of the present moment without judgment. That has a lot to do with the idea of acceptance, which is a willingness to experience one's internal responses in order to participate in meaningful experiences, right? So I can have a moment of stuttering and I can experience that, I can be okay, and I can move forward, right? That I'm not going to judge myself, right? Because if you're really upset about your stuttering, if you're really anxious about your stuttering, frightened of your stuttering, it's going to be really hard to change it, no matter how much you practice those fluency shaping strategies, in your room by yourself. They won't work at all in real life if you're not just willing to experience some stuttering out in the real world. It'd be okay if you stutter. It's okay if you don't stutter, and allows you to use a lot of these things. So the goals are to expand present moment awareness of the stuttering, encourage acceptance rather than judgment, and avoidance of internal and external stuttering experiences, and then to promote action in areas of importance to the client. So what does the client want to do? How can we go about doing those things, right? That if the client wants to stutter less, we can stutter less. But often, often people come into therapy because their stuttering is impacting them in life somehow. So, do clients want to be involved in, an after school activity, or, talk more in class, or call friends on the phone, or, apply for that job, or whatever they want to do, right? How can we then help them to, again, we can work on the stuttering, but while we're doing that, we also need to work on really acceptance of, no matter what happens, this is okay, and I can deal with this, and I can move forward. Therapy emphasizes altering the client's relationship to their thoughts, their feelings, and behaviors surrounding stuttering, right? I can feel embarrassed, or I can feel however, but that doesn't mean it has to stop me from talking, and I can be okay with that. And also strategies to directly or indirectly alter the fluency or stuttering of the client may also be used. Finally, words are important. Use the word stuttering, right? If the person is stuttering, we need to use the word stuttering. We're going to be careful about value judgments, right? So we're not going to be, oh, he's stuttering really badly today. Well, no, that just means maybe he's stuttering a lot today. Right? So we want to use, a lot of stuttering, maybe severe stuttering, mild stuttering, right? But we're not going to use good stuttering, bad stuttering, whatever. And the idea that stuttering is like most other speech, language, or medical conditions, whether it's autism, dyslexia, high blood pressure, ADHD, type 1 diabetes, heart disease, on and on. There aren't cures for any of these things. There's only management, and people can manage their stuttering really well. And that's important to remember. Thanks, everybody.